So, welcome Dr. Kareeshma. She is Medical Director of Jihan Eye Clinic, and she has completed her basic course from Bombay City Eye Institute, has done her fellowship in Narayan Nethralaya, and she has lectured in various national and international conferences, and an excellent surgeon that I know of. So, welcome to you, and over to you.
Thank you, Dr. Bindu. Uh, so, while I'm uploading my presentation, I completed my DNB from Bombay City Eye Institute, where at that time back then we used to use a very personalized way by Dr. Kothari to use calculations for post refractive cases. Then I went on to do my fellowship, where I learned a totally different method. And after my fellowship, I happened to have another IC in the next year with Tanvi, where she uses a completely different method for post-refractive IOL power calculation. So the take-home message at the end would be you have to do whatever floats your boat and whatever gives you the most predictable result. But for now, I'm going to speak on what technique I use most frequently and what has worked well in my hands. So the tools required for, can you see my slides?
Yes.
Okay. So the tools required for calculation of the IOL power of any post-keratorefractive surgery would first of all be topographic data, like Dr. Bindu has already highlighted. Um, uh, an IOL master or a lens star, basically optical biometry would always be preferred if available, especially in metro cities where now they are even available on rent. Even if you don't own one, you can always call for it. Otherwise, you should have a constant, accurate immersion biometry, ideally, otherwise optical biometry. If available, pre-LASIK data is best to have. So being a refractive surgeon, what I do for all my LASIK patients is I give them an entire file with their pre-LASIK IOL master as well as their pre-LASIK topography fed into one sheet. And a year after the LASIK, when they come for a regular follow-up, I do the entire workup again, which includes the topography and an optical biometry, and I feed in all that data into a separate sheet and again give it to the patient as their post-LASIK data. This is the post-LASIK data which is stable after 1 year of surgery and prior to the development of cataract. And lastly, what I use and what I'm going to be talking about is the use of the online IOL power calculator. So what to do when the patient comes in your OPD? Check, first of all, do you have access to topography? Do you have the topography yourself? If yes, you do it. If not, please do not hesitate to refer, because you would need a topography in a post-keratorefractive surgery patient for sure. All right. You go on to the IOL power calculator on ascrs.com. So this is the calculator that I have used and what I have got most accurate results with. And it shows you, once you click on it, it shows you the option of prior myopic LASIK or PRK, prior hyperopic LASIK or PRK, and also prior RK. And it also tells you with each update that it itself undergoes, it tells you what all it has changed in the formula, what formula it is no longer using, so on and so forth. So this is what the entire screen would look like for a patient of prior myopic LASIK or PRK. Initially, there's the patient data, there is pre-LASIK data. If you don't have it, you can just leave it blank. And then there is post-LASIK data, where you enter your refraction and you enter your topography. Now in this here comes the importance of the topography. It does not matter which topography machine you have access to. Even if you are sending the patient elsewhere, whatever machine they are having, they will have these particular display on their machines, and you can just request them to send you that particular printout. So that is what you need to make sure is done, after which you enter your immersion biometry data. So if you have access to topography, no matter what your topography is, starting from Placido to Shine Plug, Scanning Slit, OCT, you can just feed in your data. I'm not going to waste too much of time on this because Dr. Bindu has also covered a lot of it. So there are different Placido-based machines. Each of your machine will have that particular value. For example, in the older machine like ISIS, which is a Placido-based machine, there is an effective refractive power which comes on a holiday diagnostic summary. So sending your patient who has this machine, you ask for this diagnostic summary, and in the left bottom corner, as you can see, there's something called effective refractive power. This is what you need to feed in into that calculator. So the point is that you should know which data to pick up from which display image and feed it into the calculator. If it's an atlas, for example, Then you have it asks you for your 4 mm zone values, and this is how the display looks like. So you need to pick in the ring at the value at the 4 mm zone. Similarly, for TOMI, you have the anterior corneal curvature power map, and you take the value from that. After this, when you have fed in your data, including your topography and your biometric data, it shows you the IOL power calculation and how it is done. So on the left, it will show you using delta MR. So in case you have your manifest refraction, then the difference in manifest refraction formula will show you the values on the left. In this case, I did not have any. And on the right, using no prior data, what formulas it used to give you a value. At the end, it shows you an average IOL power in minimum, maximum, and average. So usually what we do is we always take the average power, rounded it off. So if it's 21.17, you round it off to 21.5, and then you further go on to plan whether you are going to target myopia or not. On the shine plug imaging, this is of a Sirius, but you can also use, so though I have used a Sirius map on the pentacam value, which has to be entered in this calculator, later on, me and my colleagues from Narayan Netralaya went on to show that these values should not be interchangeably used. Okay, so all these values can be fed in from whichever respective machine you had. Like Dr. Bindu already mentioned, you can take in the TrueNet power from the EKR map on the pentacam, which is most reliable. And finally, you get your IOL power. So let's move on to examples. My first example is that of a 60-year-old lady who had a LASIK done many years back and was now having immature cataract, and she wanted spectacle independence. Now, I access back then to the CSO Placido topographer. So I got her topography done. We're looking for two things, like already mentioned by the previous speakers. We're looking for a uniform central zone. We're looking for any irregularity. And of course, we're looking for the actual K value. So this was her right eye and this was her left eye. Now, when I got her IOL master done, and what I'm trying to highlight here is that if you see her values on the IOL master, the first value on the right eye for an IQ lens was 20.0, and 20.5 showed me a myopic overcorrection of -0.4. In the left eye, 19.0 is what the IOL master was suggesting. Now, if you go to the calculator and see, when I have entered her data into the calculator, in the right eye, it shows me 21. So as opposed to the previous IOL master, which was showing 20. So a 1 diopter change is what it shows. All right, in the left eye, I put in a toric lens because she had a little of astigmatism. And these were the powers that are ultimately used. Post-operatively, if you see her, in early post-operative phase itself, she had hardly a -0.5 myopia on the autoref, and her vision was unaided 6.6 and 6.9 respectively. She went further back to the US, and her vision was maintained. Case 2 is a post-RK patient with LS2 and posterior cortical opacities. This was the topography. Now, very important, the central zone is again regular, which is what you want to look at. These cases are very tricky again. You have to look at the refractive equivalent power map and take the value from there. This is what it looks like. So you have to take into consideration that the 4 mm value has to be taken. So the mean pupillary power is what you will enter into your calculator, in this case 38.28. So once you have entered that data, it shows 3.9, rounded off to 4. We did an uneventful phacoemulsification, but we got a post-op surprise of 2.25 with the slide cylinder on day 1. Now, if you see the way it progressed, it reduced over a period of 3 months. So the take-home message is that you do have transient hyperopic shifts in post-RK patients. Because their optical zone is much smaller, you always try to target a little more myopia. So what I do is I usually target a -1 myopia and take a slightly more limbal incision than a complete clear corneal incision. Also, be always ready for any of the incisions opening up. So explain that to the patient and always have a suture ready on standby, because the gape of the pre-existing wound may happen at any point during your phaco. Also try to keep your parameters as low as possible. So in summary, you do require a topography. If access to an optical biometer is available, that would be ideal. And most important is counseling your patient to not have unrealistic expectations so that you are saved the trouble at the end of the surgery. Thank you very much.